Hello, and welcome to this presentation on the use of harm reduction in pregnant populations. My name is Caroline Ballerstedt, and I am a nursing student at the Community College of Rhode Island. Today, I will be discussing the principles of harm reduction, the impacts of drug use on pregnant people, and how we as nurses can implement harm reduction strategies when caring for pregnant patients. I'm going to start off with outlining the definition of harm reduction from the National Coalition of Harm Reduction, as well as their guiding principles for this practice. So what is harm reduction? Harm reduction is a set of principal strategies and ideas aimed at reducing the negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and a respect for the rights of people who use drugs. In this practice, there's a difference between capital H, capital R harm reduction and lowercase h, lowercase r harm reduction. Capital HR harm reduction is a philosophical and political movement focused on shifting power and resources to people most vulnerable to structural violence. This includes things like legislation and government funding to public programs. Lowercase hr harm reduction is the approach and fundamental belief in how to provide these services. This involves mutual aid organizations, community care, and the actions of individual nurses. Harm reduction accepts, for better or worse, that licit and illicit drug use is part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condemn them. It establishes quality of individual and community life and well-being, not necessarily cessation of all drug use, as the criteria for successful interventions and policies. Harm reduction ensures that people who use drugs and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. Harm reduction recognizes that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. It understands that drug use is a complex and multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence, and acknowledges that some ways of doing drugs are clearly safer than others. Harm reduction calls for the non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. Harm reduction affirms people who use drugs themselves as the primary agents of reducing the harm of their drug use and seeks to empower people who use drugs to share information and support each other in strategies which meet their actual conditions of use. Finally, harm reduction does not attempt to minimize or ignore the real and tragic harm and danger that can be associated with illicit drug use. In a society that has evolved around prohibition, the war on drugs, DARE programs in school, etc., harm reduction can seem like a counterintuitive approach to safety. However, it is simply an acknowledgement that people are sometimes going to do dangerous things, and the goal will always be to minimize the potential harm that may come with those activities. You can see harm reduction in play outside of drug use all the time. Examples include hard hats in construction zones, seatbelts in cars, filters on cigarettes, as well as speed limits. All of these things take potentially dangerous activities and mitigate the harm that may result from them. There are many avenues of harm reduction when it comes to drug use. It does not have to be inherently risky or dangerous. As a nurse, would you ever reuse a syringe? Why not? Because a single use damages the tip of the needle, and reusing it would in turn damage the vein being accessed. There's also increased risk for infection once a syringe is no longer sterile. That's where needle exchanges come into play. On one hand, you are able to limit the number of used syringes in public spaces by disposing of them safely, and on the other hand, you are providing a much safer alternative to reusing and sharing equipment. This picture here shows some components of a safe injection kit, which are things that are often distributed at needle exchanges. I actually have a safe injection kit here to show you. Of course, it would include sterile syringes, tourniquets, latex-free, alcohol prep pads, triple antibiotic ointment, a Band-Aid. These are individual cookers used for both testing drugs as well as cooking them, and sterile saline bullets. You can use sterile water or normal saline. And then I believe in this picture that is a cola flavored condom. Harm reduction also includes the wonder drug that is naloxone, which is an opioid antagonist used to counter the effects of opioid overdose, for example, morphine or heroin overdose. Although traditionally administered by emergency response personnel or medical personnel, naloxone can be administered by minimally trained lay people, which makes it ideal for treating overdose in people who have been prescribed opioid pain medication and in people who use heroin and other opioids. People who use drugs are responding to overdoses much more quickly than even the first responders, which is why it's so important to supply them with opioid reversal drugs and educate them on their usage. Injection alternatives are just that, an alternative to injecting drugs. This applies to the notion that smoking or ingesting a substance is inherently safer than injecting it, both in terms of infection risk as well as risk for accidental overdose. It also involves providing services for people who smoke drugs like crack cocaine and methamphetamine as opposed to injectables. You may or may not be surprised what folks are able to smoke. I also have some smoking kits here to show you. They involve various glass pipes. This one would be used for smoking meth. These straight pipes would be used for smoking crack or heroin, and these rubber tips fit on the end of these pipes, and they protect the person using from the heat that comes from heating up this glass. And it also prevents infection if people are potentially sharing equipment. If they each have their own mouthpieces, it potentially mitigates the risk of infection. And finally, we have kits for testing drugs. So that usually involves a strip, a fentanyl testing strip, which is what I have here. They're the same type of strips that you would use to administer an at-home test on someone's urine. And they are responsible for detecting the synthetic opioid responsible for many overdose deaths, which is fentanyl. This aids people who use drugs in making informed decisions about their usage. So if they detect fentanyl in the drugs that they've just purchased, they may decide to use slower or use less or not use at all. This is by no means an exhaustive list, but it is a good starting point for us. So now that we have an understanding of what harm reduction is, you may be asking, Caroline, what does this have to do with me? And this is the point where I encourage you to explore how you feel about drug use. Do you have personal experience with chaotic drug use, either yourself or a close friend or a family member? Have you lost someone to overdose? How do you feel about someone enjoying a glass of wine after a long day of work versus someone using marijuana for the same purposes? How do you feel when you encounter someone in your clinic or your emergency department who uses drugs? How does that impact the care you provide for that person? By examining our own beliefs and understanding of drug use, we can approach our patients from a place of compassionate neutrality. Nurses are often very occupied with fixing and healing. We want to give a shot or hang an IV or bandage a wound. We want to fix our patients. Unfortunately, drug use and the social circumstances that often accompany it are more complicated than that. Ask yourself, how can I meet this person where they are without judgment? How can I meet their immediate material needs? How can I limit the harm in this situation? So now let's discuss what the scope of the problem is. In terms of general drug use, it is estimated that 11.7% of people over the age of 12 use illicit drugs in the United States. During 2008 to 2011, an average of 1.1 million emergency department visits were made each year for drug poisonings, with a rate of 35.4 per 10,000 persons. About 1/4 of drug poisoning emergency department visits resulted in hospital admission. The CDC estimates that nearly 841,000 people have died since 1999 from a drug overdose. According to the 2020 Global Trends of Harm Reduction, the instances of overdose deaths in the United States and Canada has increased over the course of the COVID-19 pandemic. According to the American Medical Association, 35 states have reported an increase in opioid-related mortality by July 2020. So let's get into pregnancy and drug use, as well as harm reduction, and how to implement those strategies in that particular patient population. In the United States, women comprise 40% of those with a lifetime drug use disorder, and 26% of those met criteria for both an alcohol and drug use disorder in the past 12 months. Women are also at highest risk for developing a substance use disorder in their reproductive years, so that would be 18 to 44, but especially between ages of 18 and 29. So this means that women who are pregnant or might become pregnant in the near future are at an increased risk for substance abuse. According to a national survey conducted in the US in 2012, 5.9% of pregnant women use illicit drugs, 8.5% drink alcohol, and 15.9% smoke cigarettes, resulting in 380,000 offspring exposed to illicit substances, over 550 exposed to alcohol, and over 1 million exposed to tobacco in utero. I believe that it is safe to say that abstinence-only approaches are not effective. Let's begin with how drug use impacts pregnant people and their fetuses. Of the 4.3 million infants born annually in the United States, at least 800,000 are exposed to drugs during pregnancy. That could be over-the-counter, that could be prescribed medications, or illicit substances. Such exposure in utero could be manifested by withdrawal symptoms in newborns, which is called neonatal abstinence syndrome. Some newborns require treatment to manage these symptoms before they're being discharged home. Neonatal abstinence syndrome is a group of symptoms that is manifested at birth by these infants once they stop receiving the drug from the mother's system. So they are experiencing withdrawal symptoms in the same way that anybody who is discontinuing use of a drug may. Treatment for this generally involves medically weaning the child from the substance using morphine or methadone, as well as monitoring the child for seizure activity. A lot of the care for children who are exposed to opiates in utero involves minimizing stimulus and comforting the child because they're generally pretty uncomfortable. This is done in an inpatient setting, and the birthing parent is also referred to treatment as well. Heavy alcohol use in pregnancy has been associated with a whole range of negative birth outcomes, including increased risk for miscarriage, stillbirth, and infant mortality, as well as congenital anomalies, low birth weight, reduced gestational age, preterm delivery, etc. The evidence for lower to moderate risk of alcohol use in pregnancy has either been inconclusive or not really shown to produce much of a risk for adverse outcomes in fetuses. However, alcohol use in pregnancy does have the most well-established adverse fetal health effects and is associated with the development of fetal alcohol spectrum disorders and adverse neurological outcomes. Pregnancy alone becomes the sort of hyperdynamic, hypervolemic state. So when it comes to crack and cocaine use, the vasoconstrictive nature of the drug increases vascular tone and can therefore restrict uteroplacental blood flow. So that can result in fetal hypoxia, restriction of intrauterine growth, as well as heart attacks and placental bleeding. There's an increased risk for premature placental abruption as well. Cocaine use can lead to tachycardia and dysrhythmias, as well as hypertension, proteinuria, and edema, which are often mistaken for preeclampsia. Infants exposed to cocaine in utero have a higher incidence of prematurity, low birth weight, decreased head circumference, and a risk of sudden infant death syndrome. The relationship between pregnancy and cocaine use is really fascinating, and I could go on and on about it, but in the interest of time, I will just include a study in my references page. According to a literature review published in the Pediatric Nursing Journal in 2020 titled Perinatal Substance Exposure and Long-Term Outcomes in Children, common problems found in children exposed to substances in utero include behavioral and cognitive issues, neurobehavioral dysregulation, delayed language development and lower school achievement, and alterations in growth pattern, altered motor development, and impaired sensory development, as well as potential for risky behavior later in life. So, what does harm reduction in pregnancy look like? Pregnancy and drug use is an extremely tricky subject to broach. If a pregnant person approaches you and asks for new sterile syringes, your first instinct may be to say no. You shouldn't be using, you're pregnant. Drugs will harm your baby. As nurses, we know how detrimental exposure to drugs can be to a fetus. But a harm reduction approach may be to say that we could prevent that baby from being exposed to HIV or another bloodborne pathogen or an infection from an abscess. If this person is asking for a new rig, it is likely that they are not going to abstain from drug use during pregnancy, and it's important that we as nurses modify our approach to this person's care. We must be able to meet our patients wherever they are in life and give them the best care possible. And oftentimes that means mitigating the risk to the pregnant person and providing treatment later to the child. While our first instinct is to just have a pregnant person abstain from drug use, I hope that I've helped you understand that cessation of use is not always an option. It's well documented that going cold turkey often means an increased risk for relapse and an increased risk for accidental overdose deaths. And in that case, we have 2 preventable deaths. If we can consistently re-examine and re-evaluate our attitudes and values when it comes to drug use, especially during pregnancy, we are going to be considerably better equipped as nurses to enter into a therapeutic relationship with pregnant people who use drugs. If someone senses that you disapprove of their choices, they're going to be a lot less likely to trust you, and they will be a lot less likely to volunteer information to you or even return for consistent prenatal care. Women with opioid use disorders often face a host of complex and intertwined issues. Although they come from all socioeconomic backgrounds, their lives are complicated by psychosocial and environmental factors. Often there's a history of sexual abuse or interpersonal violence, inadequate social support, unpredictable parenting models, poor nutrition, unstable housing, and co-occurring psychiatric conditions. Pregnant women with opioid use disorders are likely to use multiple substances during pregnancy, including tobacco and alcohol. It is also important to recognize that the consequences of drug use are not the same for all women. Poor women, Native women, and women of color are the most vulnerable to arrest, child apprehension, and poor health outcomes. But Caroline, you're saying, does harm reduction even work? Yes, it does. Research shows that harm reduction activities and approaches during pregnancy can increase engagement and retention in prenatal services and addiction treatment, increase referrals to other health and social services, and increase engagement in those services following the birth of the child. They reduce alcohol and drug use and improve nutrition. They definitely reduce healthcare costs. They improve health outcomes for both the birthing parent and their babies, including fewer preterm births and fewer babies born at a lower birth weight. They increase the number of babies discharged home with their parents following birth, and they encourage breastfeeding, early attachment, and improve overall early childhood development outcomes. So the current standard of care for pregnant people with opioid use disorders is referral to some kind of opioid-assisted therapy with methadone, but evidence does suggest that buprenorphine should also be considered. So medically supervised tapered doses of opioids during pregnancy often result in relapse and overdose, as I had mentioned previously. Abrupt discontinuation of opioids in an opioid-dependent pregnant person can actually result in preterm labor, fetal distress, or even fetal demise. During the intrapartum and postpartum period, special considerations are definitely needed for women who are opioid dependent to ensure appropriate pain management, to prevent postpartum relapse and risk of overdose, and to ensure adequate contraception to prevent any unintended pregnancies. Patient stabilization with opioid-assisted therapy is compatible with breastfeeding. And the neonatal abstinence syndrome, as I mentioned before, is expected and a completely treatable condition that follows any kind of prenatal exposure to opioids. I also wanted to highlight this particular quote from Dr. Mark Stringer of the Missouri Department of Health. He states that medication-assisted treatment, MAT, is an evidence-based practice that combines pharmacological interventions with substance abuse counseling and social support. Although not for everyone, it is an essential part of the comprehensive array of services available to people struggling with addiction or alcohol or other drugs. A paradox in our field is that although we recognize addiction as a chronic relapsing disease, some substance abuse counselors and administrators have been reluctant to embrace new technologies for its treatment. At the same time, most physicians and other healthcare professionals receive little or no training in the treatment of addiction. As a result, adoption of MAT has been slow in some areas. So as is the case with most kinds of harm reduction for pregnant people focuses almost exclusively on those who use opioids. In the 2020 Global State of Harm Reduction report that I had mentioned earlier, there's not a single mention of the words maternity or pregnancy in the entire 200 some odd page document. However, I do hope to see a shift in both the attitudes and academia when it comes to treating this very vulnerable part of our population. A multidisciplinary approach. So as we know, nurses can't do everything. So we need to kind of call in reinforcements when it comes to treating this patient population. The World Health Organization has established a list of recommendations when it comes to effectively preventing and treating substance use disorders in pregnant people. So the number one priority at this point is prevention. So we want to prevent, reduce, or cease the use of alcohol, tobacco, and any illicit drugs before and during pregnancy, as well as in the postpartum period for breastfeeding mothers. We want to ensure that women who are receiving this type of opioid treatment for a medical condition understand the risks of prenatal exposure and that they have access to highly effective birth control methods to limit any unwanted pregnancies. We want to ensure access to prevention and treatment services for everyone. All pregnant women and their families affected by substance use disorders should have access to affordable prevention and treatment services delivered with special attention to confidentiality as well as human rights. They should not be excluded from accessing healthcare because of their substance use. I know you might think that that goes without saying, but unfortunately it does not. Treatment, especially residential programs for postpartum women, should also incorporate consideration for the infant as well as the siblings. We want to respect our patients' autonomy. So the autonomy of pregnant and breastfeeding people should always be respected, and each person with a substance use disorder needs to be fully informed about the risks and benefits to themselves or their fetus or infant, and they need to also be educated on the available treatment options and when they're making decisions about their health care and care for their infant. And we want to provide comprehensive care. So services for pregnant people and breastfeeding people with substance use disorders should have a level of comprehensiveness that matches the complexity and multifaceted nature of substance use disorders in the population. So this is where nursing can really come into play. It's our job to advocate for our patients as well as educate them. So we don't just treat symptoms, we treat an entire human being. This includes their health and their material needs. People who use drugs are already at a disadvantage when it comes to access to healthcare. They face considerable risks for morbidity and mortality. And I hope you leave this presentation with a better understanding of what it means to reduce harm in your patient population. And thanks for coming along for the ride.